Hello, everyone. I'm Margarita Pinton Perez, and I'm the Community Partnership Leader with the Learning Network at the Center for Research and Education on Violence Against Women and Children. On behalf of the Learning Network, welcome to the special event titled Responding to Intimate Partner Violence and Substance Use, Sex, Gender, and Equity-Based Approaches. I'd like to start with a land acknowledgement. We acknowledge that we are learning, speaking, and hosting this virtual event on the traditional lands of the Anishinaabe, Haudenosaunee, Lenampewak, and Chenington nations. These lands are connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. Today, this land continues to be home to many Indigenous people from across Turtle Island. We give our deep respect to the first inhabitants of this land and recognize that an acknowledgement of Indigenous land and sovereignty comes with the responsibility to understand the history and ongoing impacts of settler colonialism. These impacts continue to be felt in disproportionate and everyday ways against Indigenous communities. We also reflect on those who came to this land involuntarily, particularly those brought to these lands because of the transatlantic slave trade and slavery. As the Learning Network is focused on mobilizing knowledge to end the spectrum of gender-based violence, we also recognize that today, Indigenous people face disproportionate forms of gender-based violence and a crisis of missing and murdered Indigenous women and girls and 2S LGBTQIA+ peoples. We recognize the responsibility for our work to be informed of the colonial imprint and harms that shape the experiences of GBV among Indigenous communities. We commit to furthering our work in ways that best uphold solidarity with Indigenous survivors and those supporting them. I'd like to now introduce our speaker for today's special event. We are thrilled to be joined today by Dr. Lorraine Greaves. Dr. Lorraine Greaves is the founding executive director and senior investigator of the Center of Excellence for Women's Health and a clinical professor at the University of British Columbia. She was previously the director of the Center for Research on Violence Against Women and Children. She's a leading medical sociologist and has worked in education, government, hospitals, and academia. She was appointed chair of Health Canada's Scientific Advisory Committee on Health Products for Women in 2019. She has received numerous awards for her work, including the Order of Canada and a Doctorate of the University from the University of Ottawa and a Woman of Distinction from the YWCA. She has extensively researched the issues of substance use and violence against women and contributed to practice change. She has led numerous national and international projects and has authored 12 books, 125 journal articles, 400+ reports, guidance documents, workbooks, toolkits, and articles on sex and gender science, intimate partner violence, and substance use. Her full bio can be accessed with the link that was just shared in the chat. It's a true privilege to welcome Dr. Lorraine Greaves to this special event. We are honored to have her with us today to share her expertise and insights. Please join me in giving a warm welcome to Dr. Lorraine Greaves.
Thank you very much, Margarita, and thank you to the team for inviting me today to talk about this extraordinarily important topic. As you can see, and as you have heard, we're going to be discussing in some detail the overlaps between substance use and gender-based violence in all of its forms, and what the issues are for action in particular. I'm talking to you today from Vancouver, British Columbia, and in our case, that means I am talking to you from the lands of the Musqueam, the Squamish, and the Tsleil-Waututh nations. The Center of Excellence for Women's Health is virtual. We have personnel and activities across Canada and in some cases in other countries. But in all of those, we try and pursue specifically the calls for justice and the calls for action that have been recently published in Canada that relate to our work through the Truth and Reconciliation Commission and through the Missing and Murdered Indigenous Women and Girls report. And overall, we stand in solidarity with Indigenous feminists who are trying to further this work. I'm going to discuss in all of what I talk about today, these three approaches. On top of our involvement model, which we started 30 years ago when we launched the center, which, as you can see on the right-hand side there, tries very hard to integrate all kinds of populations and partners and stakeholders in pretty well every project. We also focus quite specifically on these three streams of work. We build sex and gender science, and you will hear the evidence from that area today. And we encourage all of you to take that approach as well. And what that means will become evident. We use Sex and Gender-Based Analysis Plus, which is more of a tool to identify all the differential impacts of gender and sex on men, women, females, males, and gender diverse people. And again, you'll hear some of that today. But overall, we aim for gender transformative solutions that not only address the root cause and propose solutions to things that impact women in particular, but also try and increase gender equity while we're at it. And that last one, we find, is something that a lot of people agree with, but not a lot of people necessarily can do, because it takes a lot of thinking and effort. So having said all that, I want to talk about three main things: the interconnections between substance use and GBV. And then secondly, I'm going to talk about different substances. Substance use is not just one thing, but rather has, a variety of substances within it that all do different things to us and have different implications. And then the main part, really want to challenge ourselves to think through what GBV providers, whether you're doing a service or influencing policy, or just having a one-to-one chat, what can you do to try and respond to some of these issues? These are the key messages that you'll be left with. And I'm just going to go ahead now and illustrate them. But first and foremost, this is not a new issue. We've known about this major overlap for decades, centuries, in fact, and we have made some attempts to shift practice. Two, the substances that we have to think about continue to change and evolve, and they all have different impacts, and they all need to be incorporated in our response. Three, there are important common principles between GBV and substance use silos, as they are now often in some communities and countries, or sectors. But we urgently need to actively think through change on various levels. What can we do as individuals, in our programs, in our services, and in our systems? So let's look at the interconnections. The overlaps between these two things, as I mentioned, have been noticed forever, really. And a variety of theories and observations and relationships and correlations have been noted or preferred as explanations. And all I can say is that this is a complex relationship. It's multi-directional. It's not just causal or linear. And you'll see some of the obvious and maybe less obvious offerings in terms of explanations that have been offered. At the top circle, a lot of perpetration of violence has been linked to, disinhibition or cognitive disruption, or it's been called situational. So the notion that somebody might become intoxicated and then become a perpetrator, or that they might have their own adverse child experiences or their own trauma that they're acting out. On the other side of the coin, you can also see we've had lots of research and observation about how responding to various forms of violence, from sexual assault to intimate partner violence to everything in between, can be seen through substance use lens as a coping mechanism or a self-medication or management of one's life. And certainly with illicit drug use, there are lots of other risks and exposures to violence. Some of the early work in this, the first article, Intimate Partner Violence and Alcohol, was widely circulated well over 25 years ago. And what that one says basically is what we now all know and observe, that the vast majority of people who are in substance use treatment have had experiences of intimate partner violence. And the vast majority of people who have experienced intimate partner violence have had substance use issues or been exposed to them. So, simultaneously, you've got a couple of things going on here. You've got the perpetration and efforts to explain that. And then you've got coping with it or responding to it that individual women and some men do. We do know that there are vast overlaps in terms of the statistics. For example, women who experience IPV are more likely to smoke cigarettes and have higher rates of alcohol and drug use. And, we can look at those in raw numbers in Canada. In Canada, the overall smoking rate in the country is now well under 20%. But in populations of women in particular, such as those who are experiencing IPV, you can see rates of over 50 and 60%. Now, these issues have been interpreted. And here's an interesting diagram on the right, the power and control wheel, adapted to illustrate how substance use can fit into this. And, these are the dynamics. And I think it's really important to understand the detail here. So, perpetrators or abusers can introduce their partners to substance use. That's one route to this and can be deliberate. There is a concept called substance use coercion, which is embedded in all of these dynamics that has recently been elevated in Project ECHO, which is a resource on your list, recently come out, a toolkit for explaining how substance use coercion can integrate itself into the dynamics of violence and relationship violence in particular. But you can see there are lots of other ways that this can work. Women might, for example, want to quit doing certain sorts of substances and be sabotaged in that. Or they might not want to quit, and money for that could be withheld. Or quitting can be coerced, especially during pregnancy and postpartum. Or women can be forced to engage in sex work to make money for illicit drug habits, exposing them to all kinds of risky behaviors and risky health practices, such as being second on the needle, which increases risk of all kinds of disease. Or women may be coerced to get prescriptions for themselves written in the women's names, but then they're actually used by the perpetrator. So there's lots to think about here. And also, this diagram from Carol Warshaw really illustrates these dynamics as really not only responding and focusing on trauma, but enhancing trauma, not just for the women or the survivor of IPV, but also for their families, their children, and also not just once only, but in an ongoing way. So it's worth thinking through that this relationship is not just an overlap of statistics or prevalence rates, but it's actually a process that's dynamic and that has all kinds of arms to it. And as a GBV provider or service, you might want to think about all of this if you're not already doing that. And actually prepare yourselves for actions that we'll talk about later on that include asking about these overlaps. This is a very simple diagram we use at the Center of Excellence for Women's Health, just to remind ourselves that trauma is often the center of all of these issues of substance use, mental ill health, and violence. But the issues also all overlap. We have found it in our work impossible to extricate these influences and these issues. We rarely speak to women who only have one experience. And of course, and this is where the SGBA plus comes in, you must always reflect and react to the context. And you can see just some elements of context on this slide where you may be, for example, thinking about colonization and its impacts to this diagram. or incarceration. Or you may be thinking about issues such as poverty or disability. Or you may be thinking about what are the systemic problems in our public system, whether it's the health system or the justice system, that manifest inequalities here and perpetuate some of these issues for women. And I've put mothering issues at the bottom here because there is no doubt that the stigma of substance use engaged with mothering, pregnancy, and parenting is serious and needs our special thought and consideration. So here are some efforts that we have made to address this in Canada, and hopefully some of you have seen these things, especially the last two, which are more recent and available. But I just want to recognize that the LINK program in the 1990s was one of the first efforts in Canada to try and address this overlap by providing some tools and providing some information to both sectors. We did at CREVAC in 1996 have a background paper on this, which also surveyed the literature. The National Clearinghouse issued a report around the same time. But perhaps two of the most extensive and detailed efforts were both called Making Connections. One from Women's College Hospital in 2012, which is a curriculum which was often taken around to various shelters and GBV providers in Ontario. That curriculum lives online, and I encourage you, if you haven't seen it, to go and work through it. And then similarly, the BC Women's Hospital had a program named the same thing that also tried to address how providers could address both substance use. Now, I have to tell you, these are some of the slim, I would say, efforts over the years. You can see they go back well over 30 years. You can see, though, that in your own experience, I would hesitate to say that our responses are still very siloed. And that is really something we need to address. This isn't new. 5 years ago, The Guardian ran this article called "The Temperance Movement Linked Booze to Domestic Violence. Did it have a point?" So that article took us back to the 1870 activism on alcohol and domestic violence. And as much as we may critique the temperance movement on a variety of levels, from our vantage point in 2025, all I can say to you is that this issue isn't new, and it's not new to being observed by feminists. And it is interesting to think about how, if at all, we have progressed since then and what else we could do. So I'm going to now move into the second area and talk about different kinds of substances. I sometimes find myself in conversations where people talk about substance use as if it's one thing. And if anything I can say to you today disavows that notion. I want you to begin to think about substances separately. There are, first of all, legal substances and illegal substances. And we'll come back to that. There are those that are prescribed. There are patterns of use. There are different impacts in terms of public health. There are different impacts in terms of individual health, as you can see by the bullet there on female health being more negatively affected by alcohol than male health. There are things we don't yet know. For example, we really don't know what the long-term impacts of cannabis use are, even though it's a legal drug in Canada. We do know that the healthcare system engages in the distribution of prescriptions, and that is gendered. And overall, we know that men use more of all substances, develop more cases of disordered use than women. That is a consistent pattern across all substances. And that has an impact when we think about gender-based violence. And it has an impact when we think about how funding and how attention to substance use is distributed. Now, these substances I've mentioned, and these are the 5 that I just want to focus on today, they're different. You'll know from your own experience that if you drink alcohol, you can become disinhibited or drunk or intoxicated. It can, with a lot of use, create aggression in people. It certainly impairs our awareness and our abilities to do things like driving cars or making judgments. Tobacco, totally different sort of drug, even though it's the #1 public health problem in the substance use field. Tobacco is a very pacifying drug, if you will. It is an individual cycle where short-term stress is relieved by smoking a cigarette or vaping nicotine. It can lead to dependence, but it doesn't create the kind of behavior that is socially problematic, like alcohol might. Cannabis is similar to tobacco in those ways, except that cannabis can also create impairment and can be a problem for drivers, but often is a form of self-medication. So again, cannabis and tobacco can be seen as drugs that actually maybe help people stay calm. We'll come back to that. Opioids and prescription pain remedies. This is a mixture here of both legal and illegal ways to get opioids. They can create altered states, create craving and addiction, as we all well know, in the midst of an opioid crisis in North America. There are many, many, many factors involved in why this is a crisis, but you can see for yourself that the results of this crisis are pretty serious and can actually drive people into very dangerous situations. They can drive people into street life and into housing and food and income insecurity. So these are very dangerous drugs when an addiction has taken hold. And methamphetamines, also illegal and also dangerous, interestingly, are very cheap drugs, can be manufactured in small labs, but when taken, can create unpredictable behavior, craving, risk-taking, aggression, and criminal behavior, and have in some areas of this country ruined communities. So here we have 5 substances, totally different impact. 3 of them are legal in this country. 1 of them is partially legal if it's prescribed. 2 of them are not. They have very different impact on our social fabric, and they have very different impact on us. And this is where our work at the Center of Excellence really comes in. You can get all of these things on our website, which you can see in the resource sheet. But we've tried to summarize what some of these issues are for women and women's health in particular, including what we know and what we don't know about certain things. And interestingly, that's a lot. Let me now turn to how sex and gender integrate into our understanding, or in some cases, lack of understanding of these 5 drugs. So with alcohol, with colleagues at the center, we have done extensive reviews recently to support the new alcohol drinking guidelines for Canada. And in both cases, we looked at the impact on women and females of alcohol, and in the other case, on males and men of alcohol. And I say males and men and females and women because I'm talking here about sex-related issues as well as gender-related issues. And what we've done here is summarized, if you're interested in alcohol and its impacts, in some cases on violence, or in other cases, in general, on health and mental health, or on reproductive health. These are 2 articles that summarize all of that work. But the bottom line is quite interesting. Females basically cannot tolerate as much alcohol and get intoxicated much faster than males. There's more damage to organs, such as livers, which may be smaller in female bodies. And alcohol use is now directly linked as a cause of breast cancer. But the other part of that is that males can drink more, and males can drink more and become intoxicated. And given the gender-related factors on the right-hand side, such as masculine drinking norms, this can lead to situations that are dangerous for women. So, on the gender side, we like to think about issues such as gendered relations, gender identity, roles, and institutionalized gender, where I'm talking about discrimination that comes through our institution. We see a lot of impacts on both women and men and gender minorities and sexual minorities here, because we see sexual and gender minorities drink more. Masculine drinking norms that include things like competition and intoxication and binge drinking have an impact not just on men, but on women. And at the same time, women may be drinking to alleviate stress in those ways I originally mentioned about coping with trauma and violence. And never to be ignored, the stigma that's attached to women who drink while pregnant or mothering is serious. So serious that it has led to interventions from the state in many countries, and still does in many countries across the world. So basically, sex and gender interact to create that little box on the right. The advice we ended up having to give is that female risk, that is sex-related female risk, meant that we had to recommend lower consumption levels for women to be safe. And on the gender side, gender and men's risk really highlights the impact of masculinities, binging, context, competition, and how that might, in fact, need to be the focus in our communication about alcohol use to men. So obviously, this has a huge impact on IPV in particular, or sexual assault, or GBV more generally, because aggression and fighting can happen. Vulnerability to sexual assault can occur if intoxication is present in either party, because judgment is reduced or judgment is not as acute. And so we've got a lot of interactions here just on the alcohol front that really illustrate the complexities of this relationship between substance use in the case of alcohol and GBV. My original work, bringing the two issues together, was focused on smoking tobacco and the use of nicotine. And nicotine now is often delivered through vaping. So you will be seeing in your daily life and in your practices a whole lot of people now who are taking up vaping, younger people, and older people who are smokers may be taking up vaping in order to try and reduce their use of cigarettes. But, you know, apart from that being a number one public health issue, what does it actually mean to the women who smoke? And this quote, "Sucking back anger," should tell it all. Many of the women I interviewed to form this book had experienced intimate partner violence. And many of them spoke about how smoking had actually made them able to manage their situation and provide some sort of solace and allowed them to cope. And also had allowed them to defuse situations and placate their perpetrators in the moment. So I heard stories about the dynamics of how sharing a cigarette or lighting one or stopping for a break to smoke together was a way to defuse or de-escalate. But overall, my analysis took me to a different place. I realized that smoking for women, especially in situations of violence, but not only, actually stopped women from perhaps expressing their anger, which meant that our society didn't have to deal with it. And that's the social control part. So I ask you to think about smoking and nicotine use might look like a very private process in terms of our substance use array of drugs, but it also is fulfilling a social function. And we've dug into these notions in some detail in the years since that book was published. And we found that tobacco use and now vaping nicotine is intertwined with IPV control and gender relations more generally. So again, we have the sex-related factors. Just like alcohol, women and females and males respond differently to this substance in terms of the biological response, the metabolism, and even the responses to nicotine replacement therapy. The gendered factors, it's no secret that women have been exploited by tobacco marketing in order to create the market that we're still dealing with the after effects of. And it's no surprise to any of you just doing minor observation that smoking in Canada now is largely concentrated on low-income people and who are experiencing pressures and stresses of a variety of kinds. And as I've just explained to you, the attachment of meaning to these and function to these issues around smoking and vaping are pretty significant for women. So about 10 years ago, we did some work with colleagues at UBC on just exactly what was going on in the dynamics between heterosexual couples during pregnancy when tobacco reduction was on the agenda. And we found some amazing patterns. We found patterns where men were pressuring women to quit because they were pregnant. We found the opposite, women pressuring men to quit because they were pregnant. We found, in some cases, a mutual agreement to not talk about it. We found, in some cases, working together to deal with it. But in some cases, we found that the relationship dynamic bordered on violence. And we actually wrote papers about this. So this is, a significant area where use, reduction, stigma, gendered relations all work together around a romantic or a heterosexual romantic relationship. So I encourage you to read up on that. Cannabis, I've already said, is legal. We're in our 7th year now of legality. And a recent report on the legislation and how it's going in Canada made the first point about research and the lack thereof. As I've mentioned, we actually do not know the long-term impact of use of cannabis and legal use in a variety of areas. But I just want to concentrate here on women's use and how women have told us they use cannabis and what they may use it for. And you can get all of this information and way more at our Sex, Gender, and Cannabis Hub. You can see up on the right the address. But a lot of women have talked about how cannabis is self-medication for them. Again, helpful in coping, helpful in socializing, but also dealing with anxiety and depression. And we've heard this a lot from women who self-medicate with cannabis. It's also a way for some to manage pain instead of using medications. So cannabis use, for some of you who may not know this, in about 10% of cases can lead to something called cannabis use disorder, which is a serious problem because it means you're addicted and dependent. And in the middle, you can see women telescoped faster to that problem than men, which means from initiation at first use to a full-blown disorder is a shorter time period for women than for men, typically speaking. And we don't know exactly why, but we do know females are more sensitive to cannabinoids. They do report more subjective highs and have more intense withdrawal. We also know, just like all other drugs, where women experience more stigma in using cannabis, so often delay treatment seeking. And maybe one of the reasons why they want to hide substance use in the cannabis area and prefer edible. And those things are clear from our survey work. When it comes to pregnancy, vaping, and smoking, we've recently completed some research on this topic in particular because we wanted to hear from women about why they were vaping or smoking, either nicotine, cannabis, or both together, to self-medicate during pregnancy was a big reason to deal with pregnancy symptoms. But a major reason was to hide their use and make it private from not only the general public, but also their friends and family. So here you begin to see that we have a legal drug, but it's still stigmatized for women, and in particular during pregnancy. Opioids, I've mentioned, have two branches really, and what can become start out as illegal prescribed use can move to illegal if dependency results and if prescriptions are stopped. And you know, this is a very complex area. Women have more chronic pain and get more prescriptions, but you know, this is in the context of a very, very long history of prescribing psychoactive drugs in general to women, including Valium, which many of you will know was highlighted well over 40, 50 years ago as mother's best friend, or a drug that again would be a palliative for women. In other words, like smoking, as I've described it, can actually help women in accepting their situation and dealing with their depression, anxiety, and general angst about their own status in the world or in their family, and cover that over. So I do want you to see opioids and all of these substances as being double-edged in a way. They can be something an individual takes, but they can also be something that a society supports women taking in these cases. And of course, when you get into the illegal use of opioids, as we well know, the dangers include coercive control, poor health, transactional sex, STIs, communicable diseases, and exposure to more and more violence of all kinds. So we've done some work on the mothering and opioids in particular, addressing the stigma that comes with that. And I would definitely ask you, if you're interested in that area, to go and look at those resources. Last but not least, methamphetamines, as I've mentioned, can be very destructive. It can lead to real aggression and destruction in community. The workbook on the right is something from the Thunderbird Foundation, which is an excellent description of what meth is, how it's made, and how it can work, and what impact it has on individual. On the left, we did some work a couple of years ago trying to figure out, what do we know about meth with sex and gender overlay? In other words, what can we find out that could perhaps lead us to thinking through what a good intervention might be? And we found precious little in the literature. So there's a lot of work that needs to be done here for all of us to try and understand how we can best respond to women and men who are on meth. We did find that sexual minorities and gender minorities often use meth to enhance sex, hence the chemsex movement that you may have heard about. And there are some interventions in the literature for that. But in general, we found that women's risk of GBV and IPV increases with meth use. Women's health is highly threatened by meth use, and we don't have any effective interventions yet. So, to end this section, I just want to say to you, not all substances have the same impacts or meanings. Not all substances mean the same to women or those who take them, women or men. Not all substances have the same social meaning either, in terms of the ability to control or not a group of people, but none are liberating. And it is no surprise that our books around smoking, for example, that we've published are called Liberation, because there is nothing more liberating than perhaps getting out from under dependence or an addiction. And we're currently working on an intervention actually around smoking cessation for low-income women called Liberation, to try and supplement that handbook in the middle. If you're interested in all of these drugs and the variety of perspectives I've mentioned, Highs and Lows is a book I can recommend to you that Nancy Poole and I did some years ago. It's edited. It's got perspectives from women and providers and researchers. Every substance has an impact, a different impact on those who take it, those who are beside those who take it, and vulnerability to all forms of GBV. So, Substance use cannot perhaps be thought about as one block of stuff or one thing, but I'm hoping that with that information, you begin to perhaps notice the differences in what people are doing, what people are taking. Before we talk about the responses that we can make in the GBV sector, I just want to remind you of our third pillar at the Center of Excellence, and that is gender transformative work. And it looks kind of simple. If you were trying to improve a health outcome, for example, reduce tobacco use or reduce the instance of IPV in a population or a group or in a particular woman, and you also want to improve gender equity around that issue or that person or that group at the same time, and you do so, that is gender transformative. In other words, you could try and reduce tobacco use, but you could do it by exploiting gender stereotypes, saying, oh, well, it's not very attractive to smoke, so you ought to quit. That's an exploitation. But if you try to reduce tobacco use by saying it actually is empowering or liberating to think through how your life could be different, that's getting more at the root causes around coping and trauma, and moving closer to a gender transformative approach. Now, I just raised this because I'd like you to be thinking about this as we work through these levels of interaction. So this will be our last section, but basically, I've tried to divide some suggestions into these 4 levels. As an individual, you, with an individual, a particular person, as a program, as a service, and as a system. And let's just go through them. As an individual, one of the most significant things that you can think about and do is, first of all, inform yourselves, if you're not, about the variety of substances that are out there, how they function with respect to GBV, and how you can acknowledge them, how you can name them, how you cannot ignore them in your conversations that you have with women or men or whoever your populations are in your agency. In other words, invite a talk. And I know this sounds very simple, but inviting that talk is perhaps the most important thing we could do to begin to break down the silos that we often find ourselves in. A lot of time and energy has been given to harm reduction over the years. And we certainly endorse harm reduction. But of late, there's an increased return to the notion of recovery and treatment from substance use. And I would argue applies to GBV recovery as well. If you think about these principles or this process of change, where you can improve your health, live your own self-directed life, reach your full potential, have purpose, have a community that's supportive, have a stable home. All of these are principles and goals that you could apply to both areas. So I don't think it's necessary a long reach to mention in the talks that you can create with an individual in your service or in your life or in your program, a notion of recovery that applies to both areas of their lives. And what you can add to that is some science around brief intervention. That collaborative conversation that you can build, often built on motivational interviewing techniques, which many of you will be familiar with. And if not, you can find this resource I've mentioned here on the right and others on the list, is by looking at, in a trauma-informed manner, what women already know, what women's strengths and actions have already indicated in terms of wanting to change either their substance use or their situation around violence. A lot of women know a lot of things about both areas, but having that conversation in a brief way normalizes the conversation if we do it in a linked fashion. And that alone can increase women's safety. That can be informal, it can be structured, it can be very brief, but it must be trauma-informed, which means you give women choice, or anyone choice, in that conversation. You ask them to think through with you in a collaborative way. You make it safe, and you make it strengths-based. So any little bit of change that might have been addressed already by that woman in either area can be built upon to take the next step. Normalizing this is first, and personalizing it to the kind of substance use or the kind of violence the woman or man has engaged with or been victimized by. And then getting to the point where you can encouragingly figure out next steps and say that you'll come back to it. Those one-to-one conversations can be enhanced at the program level by looking at a few things amongst yourselves, your staff, your mandate, the way you construct your program. If you have an actual program office or space, what kind of information you display, and what kind of framework you can adopt that is more like that recovery framework. And of course, what kind of programs that you can launch. First and foremost, though, little diagrams and little efforts to make it clear that there is a huge integration required around the concept of trauma that is central to all three areas can often be a key to finding change pathways with women. It can also be a key to finding change pathways with men who may be perpetrators, and some of you may be engaged in that work. So this is where you come back to what are those overlaps? How can you articulate them in a personalized way? How can you begin to talk about them in your programming? When we did a rapid review of evidence during COVID, we were looking specifically at both fields to try and figure out which field had what principle. And we found evidence that all of these principles noted here are common to both the substance use and anti-violence field. So we've got some material on this project on our website, but I'd encourage you to think through just on surface. There is probably nothing in this diagram that you would not say you could agree with. Equity, harm reducing, trauma-informed, gender-informed, and we would add sex and gender-informed, empowering, culturally safe, equity-oriented. And both fields endorse these principles. So my point here is to say that in your programming, it is not much of a step to say we overlap with the other area. If you're in GBV, that is with SU programming, and vice versa. And we encourage this kind of common thinking around these principles. And that means that we can promote recovery from both. And as mentioned, the She Recovers, or the recovery movement, is growing in size at the moment. And the She Recovers Foundation, which has long roots in the USA, is now expanding into the recovery space in Canada. And so this is an area where individual women can be encouraged to sign up, or as an agency, you can use the resources that are on this website. And there are lots of events and other kinds of tips that you can gain from supporting the recovery movement in general. So I would really suggest that you include that in your programming as well. But last but not least, at the agency level, the Mothering and Opioids project took us into a space where we talked to a lot of women who were mothers and who used opioids. And their biggest problem, not surprisingly, was with the stigma that was attached to that. And one of the things we delved into with them was how stigma manifested for them with the providers that they often had to encounter. They could be providers in healthcare services, social services, anti-violence services. They could be in as well, you know, the impacts of institutional policies that were stigmatizing. But it led us to a place where we created this workbook where we included some exercises for staff members to assess your own stigma on this issue and read about stigma reduction and even suggest ways in which you can address the stigma of your peer staff members and colleagues. So this can be a tricky area, but it's something that we should not avoid doing, not just assume that we are stigma free, but actually get into the details of that and try and address it. One of the things that we're working on at the moment is this project called Strong Women, which is a social support, a virtual social support project where we're bringing together women who have experienced both substance use and violence and creating a workbook, a 6-session support group, a handout for the providers, and a facilitator's guide. And we're in the stage now of testing this the implementation of this in a variety of places across the country. Some of you may be online today, where we're trying to figure out whether or not this works, whether or not it could be a reasonable suggestion for both substance use services and violence services to actually launch this as an adjunct to their current programming. So this is an area where we did some background work and looked at the literature and found that motivational interviewing and CBT and other kind of psychoeducational approaches were the most common in the melded interventions that we did find, and there are not that many of them, but they all had a trauma-informed approach. So this is perhaps an illustration of a way in which we can begin to build on common principles and create new programming and try and launch it in what we hope might be an effective, even cost-effective way. So stay tuned for the results of that. The third area I want to discuss is the services. How do you engage with other services in your community, in your province, in your country, in your world to create systems that work together better? You know, we have heard for decades the complaints of women who come to either health or social services for help and say, you know, I have to keep repeating myself. I don't even know what door to go to. And this is the ongoing problem around service linkage. As I've mentioned, we can link practices in both the siloed areas that we currently still work in, but this has to be an active commitment from you. This may depend on the leadership in your service or the leadership in your community, but it can be enhanced by coordinating councils, coordinating committees, shared service models, shared funding models, and all kinds of other ways in which we might begin to form more trust and more exchange of information. And this can get into some details, like what are your consent protocols and confidentiality. For women with substance use, especially illegal use, but not only, and especially in conjunction with mothering and pregnancy, can lead to the intervention of the state, the criminal justice system, and can lead to custody problems, and can lead to their children being taken away. These are ongoing and additional traumas that have been measured as kind of recreating the trauma for these women that lead them back into cycles of addiction. So that is something that is extraordinarily important with respect to substance use. And exchanging information, therefore, takes on a different import. So working together, though, on recovery goals and finding a lot of opportunities for cross-training is really critical. Some of this work is going on. I've mentioned resources already that address this, including some in Canada, but we still hear from women that it doesn't always work for them, that they need more integration, not less. This kind of service coordination is often called wraparound care. I'm sure you've heard this, but you know, when you think about it, if you see women in the middle of this diagram, and all the social determinants and range of service needs that they might have, ranging from food security to responses to violence, to health issues, to parenting problems. And you can begin to see that substance use and violence are but two of the issues in this big constellation. And, working toward a place where our system looks integrated from the woman's point of view is something we all aspire to. And yet we don't yet have. All of these share the same philosophies, though. In that project that was done around co creating evidence, a lot of the philosophies listed on the right were there. They were in common. And this is like the principle that I mentioned earlier. There is no real conflict. There is just perhaps differences of funding models, differences in mandate, differences in location that we are dealing with at the moment. And these are real differences for the women that we are trying to serve. One of the key issues in substance use has been recognition of women's goals. And I know it's also a key issue around readiness in terms of responding to violence as well. This particular diagram focuses on harm reduction and focuses on some of those responses around illegal drug use, for example. But it just kind of gets you into thinking about there are women who are not ready to change or seek any kind of assistance. And what we can do for them in the substance use area is provide outreach and prevent overdose death. It's a life and death issue. I encourage you to think about working through a diagram like this with respect to responding from the GBV sector. There are women who are not ready to change, who might not actively seek assistance. So you do outreach, you send information, you send online help, you send phone numbers, you send ways to get a safety plan in place. And then there are those women who are thinking about change. And those mean that you might have to add in a little bit of a service. And that might be the brief counseling. It might be that one-on-one conversation as you meet up with women or see them informally even. And then there are those women who are ready. And those women might be women who end up in shelters. They might end up in supported housing. They might end up in your office or in your program. So there are ways to break down how we can begin to respond in differential ways to women as they move through their own processes and move toward healing and reconnection and recovery. And Eventa is one of the sites in Calgary where we're doing one of our testing. And just the way they describe their approach is that linkage of trauma, gender, mental health, substance use, looking at the unique needs and focusing on building that coping and relapse prevention. We don't often talk about relapse prevention as much in the violence field as we do in the substance use field, but terms may be different, but the concept is the same. The notion of going backwards in substance use, of picking up an addiction again, or going back to smoking or drinking again when you've already moved through it, is a real issue and something that we use as an educational journey, something that we use as a way to build skills in women and men, depending on what kind of substance they're using and what their journey has looked like. So relapse prevention is a nice idea, I think, in thinking through how GBV responders can work with substance use, but also work with GBV and the recovery journey, and also work with a melding of substance use and GBV and what a recovery journey would look like with all its complexities that I've already mentioned. I just want to give you this set of principles too that are fundamentally relational. These were under a project called Stilettos to Moccasins, and where a group of Indigenous women worked with providers of services to say, what are the relational qualities that we would like to see as we move through our struggle with, in this case, illegal drug use? And obviously empathy and non-judgment, and they wanted inspiration too, but they really wanted the recognition of their trauma and intergenerational effects of trauma and colonialism. to be reflected in acknowledging the disproportionate rates of violence and substance use experienced by many Indigenous women. They wanted open communication, care, links to spirituality, and the promotion of momentum and a healing journey, that there was always movement and momentum. There was always recovery to seek and to get and to keep. So while this is a specific project that was about illicit drug use, I think the culturally safe, trauma-informed relational principles here could best be applied to any of our work in responding to either SU or GPV or both together. And last but never least, what can we do to change the system? I've hinted so far that there are a lot of issues in the system in terms of just the awareness of links, the ongoing construction of silos, our funding systems, the way the child welfare and justice system might respond, especially to women with substance use, but also women in contexts of violence, and how we fund blended services or perhaps not fund blended services very well. So let's look here. You might think that raising awareness of industry exploitation is not necessarily first on your list, but it is first on mine. These are books about how the system has encouraged women and girls in both cases and facilitated women and girls in both cases to drink alcohol and smoke cigarettes. The Lady Killer's book, Why Smoking is a Feminist Issue, was published in the late 70s, and it is as true today as it was then. Deadly Persuasion is one of Jean Kilbourne's wonderful products, where she draws our collective attention to how advertising and marketing is allowed still to exploit the gender and vulnerabilities of women and girls in a variety of areas, but these are just two she's addressed in the substance use field, alcohol and tobacco. So this is important because this gets at those systematic practices that we often don't even notice anymore that support ongoing exploitation of women in particular. Or in some cases, the industry has been quite expert at segmenting populations and exploiting sexual minorities, gender minorities, men in some cases, different income levels of people, ages of people, and as we see with vaping now, exploiting young people in particular. So becoming aware of this pressure that's out there that we often fail to see or have stopped seeing is number one. And these books and these ideas should be paramount in your conversations with women and in your programming. Some years ago, we used Jean Kilbourne's issue by talking to women in treatment for addiction about some of the ads around tobacco use and how they felt about them. And they were singularly incensed that they had been exploited by these things. And it did serve as motivation for them to change. So that is a big system one. But there are many other levels of system change that we need to address. The institutional stigma that's responding to pregnancy and mothering, class or race, is pretty significant. And it leads to this fear of apprehension that women experience if they are using any kind of substances and are also mothering or pregnant or trying to get custody. A lot of women are afraid to come forward for treatment because of child welfare authorities. I would say in the last 40 years, we've made tiny steps forward in progress on this issue, but not really big ones. And sometimes those are transmitted through judicial demands. In other words, judges may say to women who come before them, if you go to treatment and succeed in treatment, we can consider custody again or visitation for your children. And then women go back out into the world and find that there is a lack of gender and trauma-informed programming that is designed for them, or a lack of women's treatment programs that are child friendly, which is a significant problem still, and therefore a proof of treatment completion by them and abstinence that the judicial authorities and child welfare people want is out of their reach. So these are systemic barriers that many of you may have helped women with. We need policy action here and structural change to look at these structural problems that actually prevent us from being clear about how to create a system that is merged, that is humane, that is trauma informed, that addresses the underlying gendered caregiving burdens and pay gaps and food insecurity and poverty and trauma that exist, that actually looks at the racism and ableism and sexism that underpin this, and ask specifically for these structural matters to be dealt with through funding. The issues here look big and hard to address, but any of you who are listening who might be involved in policy work or in advocacy work can think about how a simple switch, like the one on the right, which is a diagram from our Mothering Opioids booklet, where we focus on getting people in policy positions to understand that the primacy of the mother-child unit as a unit is something to build policy around, not a mother over here and a child over here as if they were two separate entities. And that alone is a shift in thinking that you might want to think through and encourage. So as I end, I want to thank you for your attention. I hope that you have begun to think through substances less of a block of things and more as separate things that have different impacts on people and different meanings, and that do feed into not just individual ill health, but also contribute to vulnerability to violence, contribute to actual perpetration of violence, and contribute to social control, where we actually keep women in particular, but not only, from reaching their best selves or from becoming liberated. There are many manuals here, some of which you may recognize, some are Canadian, some are not, that can help you, and they will be in the resource list. As I said, this is not the first time we've talked about this issue. We've been talking about it as a society for hundreds of years, and in Canada specifically trying to do something about it for 30 years. And I really appeal to all of you to take some of this information today as perhaps new ideas or old ideas, refresh yourselves or reinvent yourselves, and try and work together to make more significant change in this area. Thank you.
Thank you so much, Dr. Lorraine Greaves, for that really rich and detailed presentation on intimate partner violence and substance use. It was really helpful that you walked us through the different substances and highlight, that not all substances have the same impacts. I think that's an insight that will help many of us in our work. And we are really privileged to have you share some survivor-centered strategies, practice, and action across the different levels. I want to turn us now to the Q&A. We have about 20 minutes together. We've gotten some really great questions from the audience, and I just want to say to the audience as well, we welcome you to continue submitting your questions in the Zoom Q&A box, and we'll do our best to address as many as possible. So Dr. Greaves, I'm just going to switch us into Q&A mode here, and I'm just going to open up some of the questions. So one audience member asks, I've heard that the aggression we see in North America with the use of alcohol is not actually consistent across the globe, that perhaps there's a cultural element that plays a role. Do you think that this is another piece to consider with the differentiation with substances and therefore how they intersect with GBV?
Yes, I think that's a really interesting question, actually. Again, probably a complicated answer. The aggression that we noticed in our evidence review was, as I mentioned, often linked to what we call hegemonic masculinities, this kind of notion of masculinity in a traditional sense exhibiting or inhabiting concepts and practices like competition or strength or aggression as being masculine things that drinking alcohol for men in particular enhanced. At the same time, femininities haven't come under the same kind of level of scrutiny. And, you know, I think it behooves all of us to think about how hegemonic femininities or things that might be ascribed as traditional femininities may also, in some ways, affect the way alcohol is used and increase vulnerability. There are cultural contexts where aggression is not necessarily the prime result. But one of the things that we noticed a lot of literature on in terms of countries like Canada, for example, Australia, New Zealand, UK, USA, Europe, is that sometimes the context in which alcohol is used among men can contribute to issues like on heightened aggression. Those contexts are things like fraternities, military, bars, college campuses. I think in Canada, we've recently seen a very high profile sexual assault case involving sports figures, for example, where alcohol was clearly a piece of that story. And what can happen in that context is that the bystander qualities or skills that some men may have prevent them from intervening and stopping that kind of action. And women can become more vulnerable to sexual assault. It's a tricky area because we don't want to blame victims for being in those situations. And we certainly don't want to promote the idea that all men's use of alcohol or all women's use of alcohol is going to lead to violence. That's not true. But there is a huge overlap. But I think coming back to the question, the notion of including culture in that is a pretty significant thing. And I think if we were to do a global review of evidence, I think we'd probably come up with a lot of examples where violence and aggression is not necessarily the result of alcohol use.
Thank you, Dr. Greaves. There's another question that came in from an audience member who's thinking about your emphasis on social acceptance. So they asked, regarding the level of social acceptance of cocaine on TV and in movies, has this substance specifically been examined regarding the overlap with GBV and mental health?
Good question. We haven't done a lot of work on cocaine, and we would like to do so. So I can't really speak to that specifically because I don't think we've reviewed the evidence on that recently. But with a cocaine addiction, and if you enter into an illicit setting where there's a market where you have to access cocaine illicitly, all of those factors that I mentioned around illegal drug procurement come into play. And that means that there is a higher risk of crime engagement, transactional sex, and vulnerability to violence. And we often find that cocaine is used in conjunction with many of the other drugs that I've mentioned. I'm not going to draw a generalization right now because we also know that cocaine is used across classes and in across contexts by both men and women and gender diverse people. It can be done in ways that don't lead necessarily to dependence and addiction, but it's also very vulnerable to leading to dependence and addiction. So I think that's a great question, and it's something that I think maybe we should begin to look at more closely about just exactly how it interacts with GBV.
Thank you, Dr. Greaves. There's excellent questions coming in from the audience. Another question here is, what do we know about the relationship between alcohol use, GBV, and concussions?
Oh, that's interesting. You know, many of you in the GBV field will know that there has been increased attention in the last 10 years to researching the notion of traumatic brain injury and concussion included in that, and sometimes permanent brain injury among victims of violence. And that research is extraordinarily important because it looks at both sex and gender issues in the sense that it looks at some of the biological factors about female brain in many cases and how it is responding to trauma, and how there may be permanent impacts and permanent damage. So I would, we're not doing any of that research, but we certainly do follow it. And I would say it's a very promising area because traumatic brain injury, as anyone knows, can have long-term disabling effects. And, you know, I think the story is yet to be told about how much of traumatic brain injury, how much of brain injury in general in women is linked to violence, and or in men for that matter is linked to violence. We certainly know in other areas, like looking at brain injury, acquired brain injury and concussion in sport, that there are ongoing impacts. But a lot of that research has been focused on male sports players. So this is a whole area where applying some of those same approaches and principles to research are being applied to women who have been subjected to physical violence. So I think that's a great question. I think it's an area that's growing, and I would not be surprised in the future to see that the overlaps between brain injury, acquired brain injury, and GBV are significant and may require a very different kind of policy and practice response from us, and certainly different funding streams in research from research funding organizations.
Thank you, Dr. Greaves. There's a question here that says women tend to seek support and access social and health services more than men. Might that be a factor in women's rates of prescription substance use? Is that something to consider when interpreting those rates?
Yes, it is. Women do present themselves much more often to healthcare for a lot of reasons, and that's always been true. A lot of them are connected to reproductive health as a way in. One of the reasons why we've done extensive work on that nexus between reproductive health and substance use and health systems in our work, getting healthcare workers and reproductive healthcare workers in particular to note substance use on intake file, so that those conversations can begin. But specifically, yes, it is, plus the incidence and prevalence of chronic pain in women. Women have more chronic pain. We've got some resources on our website about that you might find interesting as providers of GBV services, because it might come up for you. That there are many ways, as you've seen already, that women respond to pain by self-medicating or by receiving prescription. So chronic pain is an ongoing issue. Self-medication is sometimes to replace those issues, and sometimes it is in the form of a prescription. However, I do not ever want people to forget that there is a long history to prescribing drugs to women by healthcare practitioners that is a form of social control. And early indicators of the use of Valium and other barbiturates in the 50s and 60s made that very clear. It is a way historically that women have been subdued. So I think you have to address prescribing with a big critical and open gaze. Yes, women are asking for help more. Yes, women have more issues in the pain department, which may lead to prescriptions of opioids. And yes, we have sexism in our healthcare system to this day that may be bringing some of those old-fashioned attitudes to the fore and offering prescriptions when other things might be a more appropriate response.
Thank you, Dr. Greaves. It's very important to hold all of that into consideration that you're mentioning. So I'm just mindful of the time, but we have some really excellent questions, so we'll keep moving forward here. There was a question here around, are there standard interventions that are specific for women in perinatal period that experience co-occurring issues? Meaning here being pregnant, experiencing IPV, as well as using substances?
Standards. We're constantly improving standards in Canada in the healthcare system and often produce guidelines. We certainly have our opinions based on our evidence and work with treatment providers across that spectrum of services about what could be included. And we're currently looking at what treatment could look like in Canada in a more ideal sense. We have a couple of projects underway about that. But I would say that the guidelines come from colleges often, from various professions. And that might be obstetricians on one hand, it might be social workers, it might be other groups that have guidelines. We have done work over the years at the Center of Excellence in introducing training or developing, co-developing training with those kinds of groups to try and influence guidelines. I've already mentioned that the idea of trying to get data collection systems to include substance use and issues around violence are certainly important. And then we can begin to have a much more solid statistical picture. I know there are issues in screening that we have been collectively debating for decades, and so I'm not glossing over those. But it is true that we don't have one general approach that is adhered to by all comers and through all those doors in all of those areas. And we need to perhaps do some work. I'm not sure it would ever be one single approach, because each door, while it might be open to a woman, might have a different context. And each woman ultimately is in a different context as well. But there are certainly shared principles, as I've tried to say. There's shared evidence, and there could be shared training.
Thank you. Thank you. That's very important, and hopefully we do see that further in the future. We had some questions that came in as well, Dr. Greaves, that were related to thinking about this topic and thinking about youth. One of the questions is, are there any indications that substance use intersects differently with teen dating violence or youth experiences of IPV? And how might GBV workers adapt supports for younger populations?
Well, the specifics of that question, I think, are still to emerge in many cases about what those dynamics are. The dating violence dynamics, though, have been mapped onto power and control wheels and other sorts of tools to try and get a sense for how young women and young men or young sexual and gender minority individuals might operate with some of those pressures and processes. So I don't think that's new, that there would be some differences. With respect to the substance issue, cannabis is legal. Cannabis is used, it's not supposed to be legal for people under 18 in Canada, and in some provinces 19, but it is used by youth. The dynamics around cannabis, there have been some bits of research on in Canada and elsewhere about how gender relations fit with those, and how differential patterns emerge. Similarly, tobacco is used by youth. Similarly, alcohol. And when you think about those three legal drugs, we often, because they're not legal for youth, we often think about that as kind of an adjacent problem. But in fact, the gendered relations that are youth-oriented require us, I think, to create a response that is youth-oriented. And I don't generally use the word youth. I tend to use the word girls or boys or gender or sexually diverse youth, because we have to think about the sex-related impacts as well as the gender-related impacts in those age groups and dependent on the drug. And so what that might mean, I'll just give one example. We hear a lot still about the problem of smoking during pregnancy. And yet when we analyze that problem in Canada, there are virtually just handfuls of women who smoked during pregnancy who are over 24 years old. The issues around smoking in pregnancy are young women's issues. They're girl and young women's issues. And yet our interventions about responding to that have really not identified that as the key message or adapted it to youth culture. So there's just one example where we could, I think, do tons more work on all of these substances in all of these areas with respect to how they interact with GBV, dating violence, sexual assault, sexual harassment, and all of these other kinds of issues that young women experience. So yes, I think there's loads of work to be done there. And I think maybe some PhD students in this audience might want to think about that more deeply.
Thank you, Dr. Greaves. So I am mindful of the time. We will likely only have time now for one more question here. I believe here we have on the issue of polysubstance use, specifically the use of opioids and stimulants together. Is there evidence on how this is affected by or related to IPV or other forms of GBV?
I don't have that at my fingertips in terms of an evidence review that we may have done on both of those things together. But we do know with stimulants in the meth area, it's very much linked to aggression and violence and unpredictability. We do know with opioids, especially illicit opioids, all the issues I've mentioned earlier about how in both cases, if you're in an illegal context, you're entering into a whole range of other issues that are vulnerable to violence and GBV, such as street involved issues, transactional sex, sexual assault by strangers, and all kinds of other forms of violence. So it's just a general answer, but yes, there would be heightened risk.
Thank you, Dr. Greaves. That's all the time that we have today. So I want to say a big thank you again to you for your time today. We really value and appreciate this presentation and the detail that you offered everyone today. I also want to just take a moment to thank everyone who joined us today for all of your engagement, for submitting questions. It is all the time that we have, and I want to send a special thank you as well to the rest of the Learning Network team behind the scenes. We have Esther, Jenna, Laura, and Nicole, and thank you so much to the ASL interpreters, Christopher and Chelsea, who are here today. Just a friendly reminder to please complete the evaluation form to receive a certificate of participation. A link will automatically open in your browser after the event has ended. If we have a moment to share the screen, I do also want to invite you and to join us for our next webinar as part of the Learning Network and Knowledge Hub webinar series titled Preventing Intimate Partner Homicide, Reflections from Members of the Domestic Violence Death Review Committee, Part 1. The session will take place on September 23rd, 2025 from 1 to 2:30 p.m. and will feature members of Ontario's multidisciplinary DVD-RC committee. They will share their experience on the committee and insights from an upcoming report. Thank you again to everyone here and a big thank you to Dr. Lorraine Greaves.
Thank you.